Okay, everyone, I think we'll get started. Before I forget, I just want to remind the trainees to make sure you sign the sign-in sheet up front, because remember, this is will count towards your attendance for the Libin as a bonus. So just a reminder, I'll start with our land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to Métis Nation within Alberta, Nose Hill, District 5, and Elbow, District 6. So it is my pleasure to introduce a fairly new member of the Libin Institute, Dr. Amy Johnston. She is an epidemiologist and assistant professor in the Department of Obstetrics and Gynecology at the University of Calgary. She holds a PhD in epidemiology from the University of Ottawa, along with a Master of Science in Health Services Research and a Master of Biomedical Technology, both from the University of Calgary. In 2018, she earned professional certification in public health, and her research focuses on women's cardiovascular and reproductive health, patterns of healthcare use, and the application of innovative research methodology to address critical gaps in evidence and care. And today she will be giving a talk entitled Women's Cardiovascular Health, Women's Reproductive History and Cardiovascular Disease Risk, what we know, what we don't know, and how we can fill the gaps. Amy.
So hi, everyone. Thanks for those who are here in person, and hello to everyone who is joining virtually. So here's the title slide, and I won't repeat the territorial acknowledgement, but I do want to just acknowledge the special place and relationship that Indigenous peoples do have with this land. So I'll get right into it. What will I cover during this presentation? So 4 key things. I'll start with why it's important to study female and women's health generally. Then I'll move into what we know about the association between female reproductive health and cardiovascular disease risk. Then I'll highlight some key gaps in our current knowledge about these associations, and I'll end on, I hope, a positive note by highlighting some practical ways that we can begin to address these gaps. Just a quick note or disclaimer before I proceed. Most of what we know comes from observational studies, and so there are inherent, limitations to those study designs, which we'll talk about near the end. But also, I haven't done a formal risk of bias analysis on each and every study. Again, there are probably inherent biases and so on associated with some of the effect estimates that are reported. So I don't focus on necessarily the precise effect estimates, but what I do is during this presentation, what I'd like to do and what I will do is really focus on the results that are supported by the majority of the studies and so on. So again, a quick note on terminology to make sure that we're on the same page with respect to the language that I will use. Biological sex refers to physical and physiologic attributes. It is not strictly binary. Intersex people do exist, and variation is normal. Gender is also not binary. It's a social construct. It's shaped by roles and behaviors and expressions and identities. And I will aim to use inclusive language throughout. Oh, actually, hold on. Yeah, sorry, there was a bit of a hiccup here. So I will aim to use inclusive language, and sometimes throughout the presentation, you'll hear me say things like male and female, or man and women, and so on. But those really are a reflection of the studies that I am referencing. So this presentation is going to focus on females. So those individuals with XX chromosomes, those individuals who have reproductive anatomy that enables menstruation and pregnancy, this does not always align with the sex that someone was assigned or presumed to have at birth. This is not meant to be exclusionary, but this is the population I'll be focusing on. So why should we study female and women's health? Well, we got things very wrong. Very, very wrong. Lots of misconceptions. I highlight two here. Ancient Greeks believed that a restless uterus could move around the body and cause illness, dislodge itself. And that was referred to as the wandering uterus, the wandering womb. And this view, we can thank Hippocrates for this. So thank you for that. This shaped medical thinking for centuries. In the Victorian era, really little had changed. Reproductive organs were blamed for mental illness. Hysteria became a blanket diagnosis. And hysterectomies, actually, hysterectomies, were routinely performed as treatment. You may think, oh, by the 20th century, we got it right. Not really. Freud reinforced these ideas, framed hysteria as uniquely female. And it wasn't until 1980 that hysterical neurosis was finally removed from the DSM. So you may be wondering, why is there a picture? I know you probably can't read the caption, but why is there a picture of females by a train? Well, it was once believed that a woman's uterus could fly out of her body when she or they were on a train and it reached a certain speed. And of course, we can't have uteruses wandering around our pelvic cavity. So we still have a lot to learn. Female body was considered too complex to study throughout medical history. Instead of investigating these important differences, we just kind of said, oh no, we're just going to avoid it. For decades, women were rarely included in clinical trials. CIHR has, I think, as a positive note, introduced sex and gender-based analysis since 2010. But a recent study noted that less than 6% of Canadian research funding actually goes to women's health. Females, intersex people, gender minorities have paid the price. So as noted here, females are at higher risk for adverse drug reactions, and some medical devices perform less efficiently and less effectively and safely, of course, in women. And so I think all of this, unfortunately, points to the fact that women are understudied and underrepresented in research and undertreated, especially when it comes to cardiovascular disease. But including females, checking that box is not enough. We actually have to do adequate and appropriate analyses, gender and sex aggregated, report sex disaggregated results. If there are differences that are important that we should be identifying that are true, then we need to report those. The room got very dark. So what do we know now? Let's start with, kind of orienting ourselves to differences on average between male and female cardiovascular physiology. So female hearts are smaller overall and in general, and even after indexing for body size, females tend to have smaller left ventricular chambers. And of course, that has implications for stroke volume. Female coronary arteries are also smaller. Heart disease in females often appears more in the microvasculature compared to males. So comparatively speaking, we see less obstructive coronary artery disease. And the last point here, females tend to have slightly higher resting heart rates compared to our male counterparts. And it further increases during pregnancy. One thing that I will point out, I'm not going to spend too much time, but I really felt, I put this in, took it out, but I really feel like it's important to highlight SCAD. So it's a female predominant cardiovascular condition. It's really quite rare. It most often affects females in their 40s and 50s. It can affect men and anyone, of course, at any age. SCAD is a type of MNCOA. So myocardial infarction with non-obstructive coronary arteries. I mentioned that in the previous slide. So it involves a tear in the coronary artery wall, meaning that the myocardial infarction, the MI, occurs really without plaque-related blockage, as we would see in other types of MIs. It's a leading cause of pregnancy-associated MI, but it rarely occurs in pregnancy. Typically, if we're going to see this, it occurs within 6 months of delivery. Mechanisms unclear, but you may be thinking, oh, hormonal influences it may play a role. Yes, that's strongly suspected, but is underdiagnosed and undertreated because of who it affects. Tends to be younger female patients without traditional cardiac risk factors. So let's move on then to speaking about female sex-specific cardiovascular disease risk enhancers. So we know that traditional cardiovascular disease risk factors, chronic hypertension, hyperlipidemia, diabetes, are important for everyone, but they're especially important later in life. Females have several sex-specific risk enhancers that influence cardiovascular disease risk. Some of these are listed here. This is not meant to be inclusive, all-inclusive, I should say, but I'm going to focus on the ones that are listed. So reproductive life events, so menarche, sometimes I call it menarche, French influence. So menarche, pregnancy, and menopause. There are also diseases associated with the female reproductive system. I wouldn't call these gynecologic conditions. We'll talk about that as we move forward. But they do only occur in the biologic female. And so this is, and some intersex individuals, I might add. So endometriosis and polycystic ovary syndrome. And I think, as we go through, I think, something to keep in mind is, what's the pathway? How do these factors and these conditions influence cardiovascular disease through direct and or indirect mechanisms? So think about that as we continue through. I'm not going to focus too much on this other than to say that I think it's a really great summary that kind of shows the reproductive life stages and kind of gives us an indication of kind of the life course perspective here, which I'll touch on. Keep that in mind, life course. This is a figure by Nichols and colleague that it's their study in 2024. And I think it does a really good job at kind of reminding us that, these stages are not isolated events. So what happens at puberty and pre-pregnancy, maybe that shouldn't be considered a distinct event, but part of a continuum. And so bear that in mind as we move forward. So let's talk about reproductive life stage 1. I'll be following those different stages in the presentation as kind of a template. So what happens in the puberty and pre-pregnancy period that can have an influence on cardiovascular disease risk for females? Well, I think the obvious place to start is menarche. First menstrual period. This typically occurs, quite a range, 12 to 13 years. But I think importantly, this is something that's strongly shaped by genetics. Some estimates put it at about 60% heritable. And it has additional influences, which I think people maybe don't really think about. Socioeconomic conditions, overall health. So things like nutrition and physical activity. Studies have shown that both early and late, and this will be a trend as we move through, early, late, outside of the norm. If you think about a normal curve, so anything outside what is considered normal, this is associated with adverse health outcomes. So for example, studies have shown that there's a high risk of metabolic disease, cardiovascular disease events, in people who experience menarche at less than 12 years of age. The same thing, we see the adverse effects of late onset menarche, particularly in individuals who begin menstruation at more than or 16 years of age or older, I should say. And this has been associated with increased risk of cardiovascular disease, and particularly the studies have reported on coronary heart disease. What about the female menstrual cycle? This is something that's considered to be a vital sign of reproductive and actual overall health. And it typically occurs about every 21 to 35 days, although it differs depending on the source that you look at, which I find very interesting. And so short cycles, long cycles, irregular cycles, which are very difficult to define because what's irregular for one person may not be the same irregularity for another person. But all of this to say, short cycles, so less than 21 days, have been linked to things like earlier menopause and more severe menopausal symptoms. And other things, more upstream, like coronary artery disease, as well as myocardial infarction. Long cycles, we see the same types of things, although studies point out that longer cycles are associated with higher BMI, insulin resistance, as well as pregnancy complications. So these are things like preterm birth and low birth weight and gestational diabetes. And of course, irregular cycles, so everything in between, everything outside the range of normal. Again, all of this keeps pointing to higher rates of cardiovascular disease and cardiometabolic disease. So we've finished the kind of first puberty, pre-pregnancy phase. Now, noting that not everyone who is capable of becoming pregnant does, but for those who do, pregnancy is considered to be a cardiovascular stress test for the body. People have to adapt tremendously to meet the metabolic needs, to meet nutritional needs and so on of the fetus, but of course for the pregnant person as well. And so these differences, these metabolic, the increases in metabolic activity, I should say, have been likened to endurance athletes, so running a marathon or ultramarathon runners. And so there's a lot going on. It really is a stress test. When complications arise, this is thought to be a failed stress test. So you failed to meet the requirements, you failed to adapt to this challenge. And so this may indicate a few things. You may have underlying cardiac pathology that no one knew about until, you failed the test. And so that's an indication, that's a red flag. It may actually create damage. So specifically with respect to HDP, hypertension in pregnancy, we can see accelerated vascular aging. And these harmful effects on the vasculature have been shown to persist. And like everything, nothing is necessarily, I don't think anything necessarily is black and white. It's probably a combination of both these things. So I'm not going to spend too much time on talking about specific pregnancy complications. I do have a nice summary figure here, although it is out of date because it was published in 2018, that focuses on hypertension in pregnancy. But just know that several different complications are associated with the development of metabolic syndrome and and cardiovascular disease. So they're listed here: gestational diabetes, pregnancy loss, and so on. And I think with respect to HDP, why I like this figure is it really points out the diversity and that not everyone experiences the same path. And so we have to think about pathways and pathophysiology and think about what might be driving these associations. And so different events as well, and combinations of different events may also shape the likelihood of coronary artery disease, coronary heart disease, heart failure, and cardiovascular death, and so on. Another thing to think about, which, I think before I started studying, female reproductive health, I didn't really think about until I kept reading papers that were saying this over and over again. And I thought, oh my goodness, interpregnancy interval. So this is the time from one birth to the conception, I should say, of the next. This is also linked to cardiovascular disease in a J-shaped fashion. So one study found that there's about a 2 to 3-fold higher adjusted hazard of a first cardiovascular disease hospitalization or cardiovascular disease-related death among those with a very short IPIs, interpregnancy intervals. So this would be like less than 1 year, and very long interpregnancy intervals of about 10 years or greater. And that is compared to 1.5 to 2 years, like at a very small range. Additional work shows that both short and long intervals carry about a 40% higher adjusted odds of preterm birth. And similar patterns are noted for low birth weight and small for gestational age. So given this, I think that these findings do suggest that pregnancy complications likely mediate some of this cardiovascular disease risk. But long intervals may also indicate subfertility. And that also has been shown to be associated with cardiovascular disease as well. Parity related to IPI, you could probably imagine. Parity is the number of pregnancies that reach viability. This has also been linked to cardiovascular disease risk. But I would note that this kind of definition varies according to jurisdiction. So you can see here listed, we have 20 plus 0 weeks in North America, and the United Kingdom tends to use 24 plus 0 weeks. So comparisons are a bit difficult when we look more broadly. But all of this to say, the patterns do look very similar. So you can see here on figure 1, this is from a study that was done in Iran. Number of live births on the x-axis, and we see incident cardiovascular disease. So, the more live births you have past 2, that is associated with an increased risk of cardiovascular disease. Again, 2 tends to be the kind of quote unquote sweet spot. That's what two pregnancies that go to past 20 plus 0 weeks, I should say, across the literature. But again, it's really important to understand what might be driving these patterns. Maybe low parity reflects subfertility, which in and of itself is linked to cardiovascular disease. But also, we cannot ask people. Maybe people do not become pregnant by choice. Maybe a person decides to have one pregnancy by choice. And so we don't know why necessarily unless we ask, or unless we have the data to be able to determine these factors. And so there's a lot to consider here. High parity, on the other hand, might be linked to, extensive physiological differences. Of course, I mentioned previously, and many of you, I'm sure, are very aware that pregnancy is a major stress test. And also lifestyle factors and hormonal influences as well might be driving some of this association. The last thing I'll talk about with respect to kind of pregnancy in and of itself, I mentioned this a few times, is subfertility. So prolonged difficulty in achieving pregnancy, and also infertility, which is failure to achieve pregnancy after 12 or more months of regular unprotected intercourse. Findings are mixed. And again, I think this is largely reflective of how things are defined and so on. There was at least one study found about a 20% higher adjusted hazard of a first cardiovascular hospitalization or cardiovascular disease-related event. And this is among people with 5 or more years of difficulty conceiving. But associations appear to be more consistent for unexplained, and I use quotations for a reason, unexplained fertility and incident cardiovascular disease. But this may actually be explained. This may reflect underlying conditions like mild endometriosis, endocrine dysfunction, diminished ovarian reserve, and so on. And also, unexplained fertility, studies have shown that individuals have higher inflammatory markers and lower HDL levels, which of course may also help explain some of these observations. So the last thing with respect to pregnancy in the postpartum period that I'll talk about is lactation. So as shown in this figure, I know that it's maybe difficult to see, but basically there are several health benefits, from cardiovascular to endocrine to weight and body. I mean, just so many benefits that are associated with lactation. The longer someone lactates, studies have shown that the longer these benefits actually do persist. So for example, 12 months of lactation has been associated with reduced coronary artery disease risk, and lactating beyond 1 year is also linked to progressively greater protection. And some studies have actually shown that these effects may accumulate over multiple pregnancies. So lifetime lactation. Interesting that you can get this in little spurts and it still offers, accumulated protection. So the last reproductive stage I'll talk about is with respect to the menopausal transition. So this period, perimenopause, menopausal transition, has been dubbed an inflammatory event. It's known as a period of accelerated cardiovascular disease risk. Persistent and late occurring vasomotor symptoms, so hot flashes and night sweats, are considered to be an emerging risk factor for cardiovascular disease. And again, like most of these trends that I've explained with respect to other factors, late and early onset menopause, all have an effect on cardiovascular disease. And so, it's interesting. We see these trends over and over and over and over again. Now, of course, gradual decline in estrogen is tied to heightened inflammation and a more reactive immune profile. And so these are both associated with increased risk of ischemic heart disease, which again helps kind of explain what is going on with respect to these associations. What might explain some of this association? Menopause itself typically occurs between the ages of 49 and 52. Again, the drop in endogenous estrogen removes some of this cardiovascular protection that is afforded to females. And this helps to explain why coronary heart disease tends to appear 10 years later in females compared to males. Early menopause, as I mentioned previously, adds an additional layer of vulnerability. So a meta-analysis of more than 340,000 females who entered menopause before the age of 45, and again, typical ages 49 to 52, had a 50% higher risk of coronary artery disease compared to those who went through menopause later. I would be remiss if I didn't talk about menopausal hormonal therapy. This is the term now that's used. It was referred to as hormone replacement therapy. It was introduced in the 1940s, became popularized in the 1960s as a way for women to, quote, stay healthy and remain feminine. Now, controversy, tons of controversy. It's been in the news. So you probably know about it, but essentially early observational studies were very positive. They suggested, several benefits of MRT, including reduction in coronary heart disease and mortality. But big trial came out, Women's Health Initiative, and said, oh, no, there's no benefit. And actually, it may actually increase the risk of certain cardiovascular disease, as well as breast cancer. And so this led to an abrupt stop for the use of MRT, I should say. Subsequent reanalysis of that trial, or those pivotal trials, and new RCTs and observational data, and of course, meta-analyses, have consistently shown a reduction in coronary heart disease, mortality, and of course, benefits for vasomotor symptoms and so on. But you have to get the timing right. So if you initiate it, again, on average, within 10 years of the onset of menopause or before the age of 60, this suggests that this window of opportunity offers the most benefit. I want to touch briefly on two conditions, as I mentioned previously, kind of shifting gears again to talk about female-specific diseases of the reproductive system and how they might be associated with cardiovascular disease risk. Well, let's start with endometriosis. So it was traditionally and commonly back in the day, about 10 years ago, I think, referred to as a gynecologic condition, but I think it's more appropriately referred to as a systemic chronic inflammatory condition. So this occurs when endometrial tissue grows outside of the uterus. It's now recognized, like a few other things I mentioned, as an emerging risk factor for cardiovascular disease. One meta-analysis, again, pooling of studies, reported a 20 to 50% higher pooled hazard for incident ischemic heart disease and cerebrovascular disease associated with history of endometriosis compared to no history of this condition. But I think cardiovascular disease risk factors tied to this condition, it's a chronic inflammatory condition, and endothelial dysfunction may explain parts of this association. And the next one I'll just touch on briefly is polycystic ovary syndrome, PCOS. It's another female-specific condition that's linked to elevated cardiovascular disease risk. It's the most common endocrine disorder in the reproductive years. It's a very strong, it's very strongly, I should say, associated with infertility. Variable symptoms, though, anything from excess androgen, I should say, to irregular periods, none infrequent or long periods, elevated BMI, insulin resistance, and so on. It's associated with risk of subclinical markers of cardiovascular disease. Some studies show risks of coronary artery disease and stroke associated with a history of PCOS. especially earlier onset, so before the age of 55. So, others have highlighted, and I think this is really important to mention, is that there are different phenotypes, PCOS phenotypes, and studies are really starting to urge, and I think this is a good thing, that we need to start studying different phenotypes, because different phenotypes may be associated with stronger or less strong risk for cardiovascular disease. So just a few more things to cover. It appears as though we know a lot. We've learned a lot, but this raises questions about what we don't know. So I'll cover these in a couple of slides. I'm sure there are many more that I haven't thought of. Maybe you have thought of some as well. But essentially, there's still a major gap in evidence. What do I mean by that? I mentioned the use of observational studies. However, I will say I will take a well-conducted observational study over a poorly conducted randomized controlled trial any day. New study designs that offer some benefit, like Mendelian randomization. These studies, again, if you don't do them properly, if they're not rigorously conducted, they also have flaws. But I think we're moving in the right direction, which is nice. We're trying to find new and unique ways to come at this from different angles and using different study designs, which is great. I'm an epidemiologist. I use administrative data. I care a lot about case finding definitions. There's a lack of validated case finding definitions, I should say, to identify these conditions from administrative data sources, electronic medical records. And we still don't know exactly what's going on with respect to the pathophysiology and the mechanistic pathways. These remain underexplored, and I think warrants a lot more research. But a key part of this is, if we don't know to ask, we won't ask. And so in clinical care, unfortunately, reproductive history is rarely included in cardiovascular disease risk assessment, although I think we're doing a much better job. We still need to continue. In administrative data, we really don't have, unless you're really lucky and you have that database you can link, we really don't have reliable data on timing of menarche, timing of menopause, menopausal symptoms, and almost no data on pregnancy loss. And even if we have the data, how can we use them? Ideally, we would account for reproductive life events. Think about that figure I showed you earlier on. And we would quantify cumulative risk over the life course. That's a very complicated thing to do. Not that we shouldn't try, not that I'm not trying, but if we know better, we should strive to do better. And I think this is what we need to strive towards. And as I mentioned with respect to PCOS, people have realized, there are different phenotypes. So I think we could do this as well, and we should be doing this. Maybe we should work on identifying different subgroups and different risk profiles, and that would help in cardiovascular disease risk prediction for females. Just a thought. But of course, all of this is challenging when definitions, as I mentioned kind of throughout in a couple of places, definitions vary. Outcomes that are measured vary. And so it does make it difficult to pool the data in an appropriate way, because you may be talking about apples and oranges. So that does make it very difficult, unfortunately, to summarize the literature. So how can we fill the gaps? I hope that I will leave you with some optimism in the remaining few slides. Well, again, I'm an epidemiologist, so I love statistical modeling, and I love looking at different ways to analyze things and look at address study questions. Move beyond traditional multivariable models. They have a time and a place. They're wonderful. I love them. But let's think about different ways to approach questions. So we can use causal mediation analysis. This can help clarify pathways and quantify how much of these associations can be explained by intermediate factors, metabolic conditions, for example. We could use latent class analysis and related trajectory modeling. And this, again, is what I mentioned previously about identifying specific subgroups that we can focus on. And this will help us with our kind of trajectory modeling to see what might be happening over the life course. It's a descriptive method, but I think it's very good at hypothesis kind of generation. And the last thing, but not the only thing, quantitative bias analysis. We do all this work, we generate our effect estimates, but we know that there's misclassification. We know that there's some confounding. So we need to do a better job at probing our effect estimates and saying, okay, how confident can we be? And you know, this is becoming a lot easier to do, built into statistical programs. And so I think we need to really push ourselves to do some of these analyses. We should also adopt a life course perspective. Easier said than done, I'm well aware of that. But I think it's fair to say that overall health is shaped by accumulated experiences and not isolated events. Early life exposures, social determinants of health, lifestyle factors all interact to influence long-term trajectories. And we should consider this in our study design, in our modeling, and so on, whenever we can. And I just want to point out two frameworks. I'm not going to go over them or in any detail, but I want to show you kind of two ways that you might be able to conceptualize this within, framed within female reproductive health and events and cardiovascular disease. So here's a framework Kim and colleagues published in 2023. It's kind of trying to conceptualize all of this. It explains how potential shared mechanisms between demographic and sociodemographic factors, as well as in utero experiences and childhood exposures, affect sexual maturation, which of course is a question mark, but that all of this together might influence adult cardiovascular disease risk. And another way to look at this, well, we could consider clusters of reproductive milestones, events, and characteristics, along with, of course, this always comes into play, socioeconomic and structural factors, and non-traditional cardiovascular risk factors, as well as traditional risk factors. Of course, we can never forget those, jointly impact cardiovascular disease in early adulthood and in general. So I'll leave you with this. I think we need, and I'm not the only one who thinks this, but I think we need a paradigm shift when it comes to cardiovascular disease prevention. We need to make female reproductive health a central component. I think there's been a lot of momentum, but I think we can do better. So I think the first thing, every time I think about these things and every time I look at the associations, one thing comes to mind: cardiometabolic health. We really need to focus on improving cardiometabolic health in females. It seems to be the link over and over and over again. So I think we really need to push supporting long-term cardiometabolic health in females. Clinically, we need to routinely ask about reproductive history. In research, it means we need to obtain this information and use it appropriately. Unfortunately, when it comes to risk prediction, incorporating this information has not turned out as we had hoped. It doesn't improve risk prediction when we talk about female-specific risk prediction models as much as we hoped. But that doesn't mean it's not important. That might mean, again, going back to subgroups and different pockets of populations that might be at higher risk. It means about rethinking what we're doing. And maybe we use this information to identify high-risk phenotypes to really push forward cardiometabolic prevention, of course, but also improving cardiometabolic health of these individuals. So these are selected references. I can send you or anyone upon request a full list of references. It's about a page and a half. Tons of information about this. And I think we need to keep doing more of these mechanistic studies and keep doing more, improving our models and keep learning. And one last thing I will say is we're at Canada, February 13th, this is a national awareness event. It occurs every year on this date. And it's all about raising awareness about women's and females' heart and vascular health. And it's targeted to Canada. So I encourage you all to go to wearredcanada.ca, check out the different activities, check out different things that you can get involved in. There are things happening in Calgary as well, so check that out. Here's my contact information if anyone wants to reach out. Thank you.
That's great. So, I'll open it up to questions. Jackie. Thanks, Amy.
Mm-hmm. Yeah, I mean, great question. And I think what I would say is people control for different things. And that's subject to the availability of data. I think in this particular study, if I recall correctly, they tried to control for as much data as they had. Important confounders, of course. And I think, again, to the best of my ability, to the best of my knowledge, I should say, I believe that this was, no, I can't recall which exact variables that they controlled for, but I believe that they did the best they could. And I think, one thing that I would add to this is bias analysis might be helpful. Because if you're missing these important variables, then there is data that you could use to kind of inform these bias analyses to get at some of this unmeasured confounding, which is what you're referring to. Yeah. Yeah, exactly. And I think what you're saying is, totally on point, and it points to so many things that should be accounted for or should be considered, but we might not have the data to be able to do that. And again, I'm an epidemiologist. I'll always come back to, let's do quantitative bias analysis. Let's try and probe this estimate to see what's going on. And why, to be honest, why they picked 5 years, I'm not sure. I would hope that was a priori decision. But again, I didn't do formal bias analysis or risk of bias assessments on these studies. And so it might be worth looking into that study and kind of probing what their decision-making was around that.
Relationship between that mediated.
Could be, absolutely. And so I'll just go back. I think it's a good kind of figure to pull up here. Sorry for anyone who's looking at the screen and it's kind of going crazy. Yeah, so I think you hit the nail on the head. I think there's so many factors that could be mediating these associations. And I think that that's probably one of them. But what I will say, you may say, well, all of this is due to insulin resistance and hypertension and all of this. I don't think that's the entire story. And I think this is why I encourage mediation analysis. And again, that can be flawed as well and subject to error. But I don't think it's, as I kind of pointed out on the HTP, hypertension and pregnancy slide or pregnancy slide, I think it was before that. I think certain conditions can cause harm to the vasculature, for example. And I think it can unmask certain underlying issues or predisposition as well. But that doesn't explain all of it. And so I think looking at that and really, I would say do mediation analysis on everything, but that's not going to happen. But I would say for questions like that, I think that's a perfect question to ask, to look at how much of that is mediated through weight loss or any number of different things. And my guess is yes, a certain portion of it is, maybe a huge proportion, but I don't think that explains all of it.
Maybe a mother who's able to
Well, and that kind of speaks to parity, right? And so, grand multiparity. I mean, my goodness, do you have time? Like, how much time do you have to devote to each? I mean, lifestyle factors, another huge influence, I think, that we don't often think about, but could be mediating some of this, right? And again, I think we need to take a step back and stop automatically going, yes, let's pump it into a logistic regression or a hazard or a time to event model or whatever. Let's make some frameworks. Let's figure out what might be happening, and let's draw it out, and let's figure out what we can do after we have this framework and after we have these questions. Now let's figure out, okay, how are we best going to answer these questions using this kind of life course perspective and all this, this perspective that you talked about as well. So I'll just read it. So Riza, we know that women under-participate in research. What can be done to increase enrollment and retention of women in clinical research? Oh my goodness. Somebody could do a thesis in that, at minimum a master's. I think there are so many different ways. And if I recall correctly, there have been papers, if not short reports that have been written on strategies. In fact, I think an entire book has been written on how we can make sure that females participate in studies and also they remain in studies. Childcare conferences have started including childcare. I think that's a huge step. How amazing is it? I just think back, it's funny, I just think back to parent teacher, and they said, bring your child. And I thought, perfect, we can both go, right? So things like that. You don't have to decide who's going to go. You can just bring your children while you participate. Also, think about the hours. What might be more convenient for an individual who might be a primary caretaker? How can we make this the most convenient possible? How can we make this fun? Just things like that. But, great question. And I think it's worth revisiting and making sure that, that again, we're not just check marks. We're not just, okay, yeah, I included females, great. No, we need to make sure that not only we're encouraging that, not only we can retain females and women in our studies, but that we're doing what we should do with the data once we have it.
Reading reproductive history was not so sorry.
Yeah.
For those of,
yeah.
What was incorporated and why?
Great question. So there was a really good commentary by a researcher in Montreal, I think, and a few studies and a few, I guess, commentaries that have talked about this going, what is going on here? Head scratcher. And so things like menarche, timing of menarche, and those reproductive events that I pointed out. I don't know that female-specific conditions like endometriosis and PCOS have necessarily been incorporated, but I think that kind of reproductive, exactly. So
complications?
Yes,
they were.
Yeah, and some models I believe as well. But it's funny because some people will say, well, the 10-year risk prediction, that doesn't work very well. It doesn't improve it dramatically, I guess, is the way I would put it. Let's try for 30-year. Well, people tried 30-year. That didn't improve it much either. And so it's interesting because, again, it's really surprising. I think what's happening here from a statistical perspective is multicollinearity. So you're adding the same things. If you have diabetes, and if you have insulin resistance, all of these factors, and then you add something that's associated with it, you're not adding benefit. That's not to say that there is no association. I think rather than just adding these factors into models per se, we need to use it for prevention. We need to use it as a red flag to say, uh-oh, you had XYZ. We're not going to wait for another 10 years, right? Because these conditions, you may show up at your physician at 35 years old, have all these conditions, and they say, oh, we'll wait till you're 48 to do whatever. I would hope that you would have these tests done before that. But all of this to say, momentum is pushing towards saying, okay, maybe creating risk calculators or incorporating the specific information into risk calculators isn't going to do the trick, but it's still important information, and it can serve as red flags for targeted prevention strategies, like aggressive.
Predict the onset of
Exactly.